Scenario: a teen comes into your office with his mom a day after hitting his head while playing with friends. The mother shares signs that she has noticed. He seems dazed and is unable to concentrate. He's also reporting sleepiness and headaches.
Most of what we do is going to be based on what we hear from the patient. So if this is an observed injury, we want to do our best to get the history of what occurred, what was the mechanism of injury, what was the timing of the injury. Did this occur a few moments ago? Did this occur a week ago? What were the symptoms immediately after the trauma? And what has been the progression of symptoms? And we're not just going to limit ourselves to the original things that people associate with discussing mild brain injury, such as did we lose consciousness, or did we have vomiting at the time of the injury, did we lose memory for the event. We're also going to get into a little bit more in-depth questioning, such as, since the injury, have you felt like you're not able to focus? Have you been more irritable? Have you been more sleepy is a more traditional question. Have you been able to handle looking at social media? Have you been able to handle watching TV without any difficulty or worsening of your headache? We want to talk about headache. We want to talk about the progression of that headache, the location, other associated symptoms. But we want to make sure that we're focusing on other more subtle indications of brain injury. And then, of course, we're going to move into our neurologic exam. We're going to make sure that we have a normal mental status. We're going to make sure that we have a perfect Glasgow-Coma scale, because if we have even 1 point off, that's going to indicate that we need to refer that child perhaps to get a CT scan or be evaluated in the emergency department. We're going to try a PO trial. We're going to make sure that that child can tolerate liquids by mouth. And we're going to make sure that we can control any pain with oral medications. We're checking not just higher brain functions, forebrain functions with person, place, time. We're also going to check balance. We're going to check cranial nerves. We're assessing for signs that would indicate a skull fracture. So we're looking for bruising under the eyes, bruising behind the ears. We're looking for blood behind the tympanic membrane, the eardrum, all of which would be indications of a more serious injury. And so that's a part of our neurologic assessment. What I try to provide for the parents when they go back to the administrators and explain the situation is the diagnosis of concussion, and then I provide for them a copy of what I'm prescribing for their recovery. And so that stepwise plan, the stages of recovery, I actually give to the parents to share with the teachers, share with the administrators, so they understand what steps we're looking for before we'll allow them to progress on to the next stage. That a lot of times involves a tremendous amount of education. It might involve a call to a teacher. It might involve a call to an administrator who doesn't understand the new guidelines in terms of return to not just academic work, but then return to play. We want the brain to go through the stages of healing involved with mentation, academic pursuit first. So once they can tolerate reading, doing math problems, spending some time on the computer, difficult mental tasks that would be involved in school for the school-age child or teenager, then it's a slow return, slow progression back to physical activity. And again, when you're dealing with coaches who might not be familiar with that stepwise approach and are more saying, can they go back in a week? Can they go back in 2 weeks? Can they go back in 2 or 3 days? We have a game in a week. We have to emphasize that every brain heals when it heals, and that there is going to be no set timeline for this. We're going to have to go based on symptoms when we're establishing each stage of recovery. And so counseling patients, in as much as possible providing educational materials to parents and coaches and teammates even who might be pressuring kids to return to sport or play, that we have not moved to the point where we're able to do that and do it safely. Young children may not be able to vocalize their symptoms as effectively as the older patient. So you may be able to see that they're uncomfortable. You may be able to see that they're having headache. They may be able to vocalize that, but they're not going to be able to vocalize the more subtle symptoms, that they can't focus when reading. They may not even be reading yet. that they become uncomfortable when watching flashing images on a screen. And so you're going to depend a lot on parental observation for those types of things. And a lot of it is involved in honing the parent in on looking for those particular symptoms. And you may not get all of that history in an initial visit. You may have to do a follow-up phone call with a little bit of instruction. Maybe the parent needs to maintain a symptom log, things of that nature. With the teenager, there's perhaps a little bit of a different angle. They may be unwilling to share those symptoms with you because they're receiving pressure from coaches to return to play, or just their own internal drive that they want to get back on that playing field. They may not share with you that they're still having a headache. They may not share with you that at the end of the school day they are very tired, very sore, not wanting to focus on that schoolwork because they want to get back to play. So again, it's cluing parents in on those subtle signs and symptoms that they need to be observing, and having everybody that's in that circle of caring around that patient, around that child, be looking for those things that they may be not able to share with us or may be unwilling to share with us. So we're looking for similar things. It's just how we get to what's going on in that patient's life.